We have asked two sets of panelists from our Wave 1 medical groups to join us today to share their experiences with their implementation, their patient outreach, engagement, enrollment, and the daily management of their intensive outpatient care program patients. Our guests are from St. Joseph Heritage Medical Group in Orange, California, and Sharp Reese-Steely Medical Group in San Diego, California. These are the folks you want to ask the questions to. These are the folks that have been in the administrative, directive position and also in the trenches where providing the hands-on care coordination, health coach encounters and interventions with the patients. So I've left a list of questions on your table that you can be thinking about for patient identification, patient outreach, patient enrollment, daily patient management. So look at those questions, and you may think of some of your own to ask them, but they are here to provide their insight and their expertise, what worked and what didn't.
Hi, my name is Sarah Williams. I'm the Director of Care Continuum for St. Joseph Heritage Healthcare, and I am in charge of the IOCP program at St. Joseph Heritage Healthcare, and we have branded it Care Connect.
Hi, I'm Vicki Richardson. I am a RN Care Coordinator with St. Joseph Health System. I am embedded in a busy primary care office where there's about 9 primary care family practice physicians.
Hi, I'm Jenny Ostronic. I'm a medical assistant slash health coach.
Hi, I'm Chris Tedeschi, and I'm the manager of ambulatory disease management programs for Sharp Reese-Steely Medical Group in San Diego.
And I'm Janet Appel. I work with Chris and the Sharp Reese-Steely team. I'm the director of population health there.
What is the caseload that you feel is ideal or realistic? I know we've talked about it amongst ourselves some as well, and so I know that's on everybody's mind. How many patients can we really carry?
What we're seeing right now is that at 125, the staff is extremely busy. We started this program with Vicki being by herself embedded with physicians and really worked closely with her to say, how are you? What's happening within your practice right now? When do you feel like you're at your max? And then at that point said, yes, it's appropriate for us to bring in a health advocate for her to work closely with her to spread this to all 9 physicians in her site. But it's a challenge.
To go much higher than we're at, we've got to figure out how we can work a little smarter. As a team, we're working on that right now.
So how is the flow for your day? How do you manage to have 108? I have 90 patients, and kind of like the same thing. I'm trying to figure out how to do it. What is your flow during the day? How do you manage your calls and the visits and the PCP questions and the patients that you don't have probably been out of your caseload for the last 3 or 4 months, but they're still calling you and have questions for you?
A big part of my day is looking at what patients are coming in the clinic that day. So the only way I'm doing that right now is on an Outlook calendar where I'm got everyone's patients' appointments for the day, and that's appointments with their physicians, not with me individually. Up until now, which we're rethinking, I've tried to be at all those appointments, so that makes my schedule not my own. I'm tied to the patient's appointments, which has been very difficult. I've tried to prioritize that because the physicians are expecting us to be there. If I'm not there, I get a call saying, Vicki, your patient's here. Get over here. They're waiting to see you. Another challenge with being embedded in the office is a lot of sitting around waiting for physicians. You know, you've got one doctor that runs 2 hours behind, another one that's 10 minutes ahead, and it's trying to struggle.
Can I add something to that as well? I think at Sharp Reese-Steely, what we have looked at this question, and it is a very, very important question. And during initial rollout, it was less important because everyone can begin to have a 20 or 30 patient caseload and handle these patients very well. But when it comes to follow-up, that becomes the issue, of course, along the way. Initially, we did not stratify patients as in any way. Everyone kept their patients, and every nurse coordinator continued to do the follow-up for those patients. What we have found we have to do is now we need to step back and understand who needs to be contacting that patient at what time. So in other words, can an unlicensed or MA, a certified person who has been well-trained be the one to do an outreach for follow-up as these caseloads grow over time, so that that's the person that can help manage that along the way. And we are just now looking at what that looks like.
This is a conversation that we have all the time, and I can appreciate Sarah's answer, because is it what I think your caseload should be as a director and knowing what the overall entity goals and visions are, or is it what the nurse that's actually doing the job? And I do believe in pushing, and people that know me know that I push the limits a little bit, because I feel like people will work up to their expectations. So if you tell somebody they can have 40 people, they're going to do 40 people. If you tell somebody to see 3 people a day, which is what we started out, that's exactly what they saw, 3 people a day. If you push the envelope a little bit, you see they see more and more. I think the most important thing for someone like me and someone like Chris and someone like Sarah is constantly making sure that we give you the tools that you need to be able to carry the caseloads that we want you to carry. And so that means having people doing your mailings, having people doing your communication, having MAs to do follow-up calls, being there as a resource when an issue comes up. And it is definitely more difficult when you're in the office with the patients than it is for someone who's doing a lot of the telephonic work.
At our facility and our organization, we have more than one program running. So I'm curious to hear your caseload. Is this just delegated to IOCP only, or you actually have other programs running simultaneously like we are? And also, is it just one clinic only? We have multi-clinics, and we actually have case managers that travel from site to site to site. So did you encounter those kind of difficulty as well with your caseloads?
We actually have multiple case management programs happening at the same time within our organization, which is something that we're addressing right now. So we actually have a team of people looking at IOCP and complex care management, some of our transplant care management, so all the different programs that are happening, and trying to understand how do we put someone at the helm, which is something that we actually have learned from Sharp Reese-Steely, to direct patients into appropriate programs.
We determined from the beginning that we had to incorporate the philosophy of IOCP into every program that we have. And we have a multitude of programs, you know, disease management programs. There were separate chronic care nurse programs, complex case management programs. And what we determined, if this is ever going to be successful, everyone needed to be trained in this philosophy, and everyone needed to apply this to every patient that we care manage, so that anybody who's coming in as a senior with chronic conditions can be a part of the program without having to go to one individual. And that's why we've been successful at this, because we've incorporated this. So if our heart failure disease management nurse has a heart failure patient that's a senior and appropriate, it's in the program, but she performs all of the duties that are needed.
Look at the difference in our programs. We look at the enrollment numbers that we have within St. Joseph Heritage right now, and we're at about 350 patients versus you're at 1,000. So the different approach, I think, really allowed for Sharp to enroll patients more efficiently. There's our relationship that we have within the physician office is very tight. The physicians value the input of the nurse, but it's just a very, very different approach. So I feel like our approach didn't allow us to grow as quickly as you were able to do that at Sharp.
When you started working as a patient advocate, was your role well defined, or did it develop over a period of time, or how did it work?
I actually worked for a physician that is in our office for 13 years. And so I did know all of the doctors, all of the staff. That was really helpful. They sort of had in mind what Vicki needed help with and what I needed to do. And every day is new. It's just, it's constantly evolving.
One of the things that we're doing right now, too, is actually we have 2 health advocates out there with our nurses. And so we've pulled them back in, the teams actually, a week ago to say, what's working? How do you see this evolving? What is your role now? Is it different than what you thought it was going to be? But really pulling the staff in and just having those touch points to really understand what's happening in their practices, I think has helped us as we try to define this role.
And I'd like to add that at Sharp Reed-Steele as well, as we have added individuals to the program, every single staff member at Sharp will let you know that our mantra is that change is happening. And so we look very hard for people like Jenny who are willing to come on board with the uncertainty of the process. The process of what you do may change, and it may change in the beginning weekly. That's what we found.
I know there isn't a normal day, but kind of what your interactions are like during a normal day. Who does what? How do you decide who's doing what? Those kind of.
That a lot of it is looking at who's coming in that day. And so, because Jenny's just been for 2 months, I kind of want all the patients to see her face, at least. So we look and see who hasn't met Jenny yet. So I kind of think about, okay, this is a new patient, or this is a follow-up. I've seen this patient 1 million times, but Jenny's never met him. I'm gonna let Jenny, I'll introduce him to Jenny and then let Jenny stay with the patient while I go and do something else. So a lot of tag teaming like that. I think Jenny's really stepped up to the plate to be independent with that patient.
Can you share the documentation process for the care coordinators so that the communication will promote among all the providers?
Our electronic medical record, we use Enterprise, Allscripts Enterprise, and we're also looking at a new product called Care Director, but it's still in the development phase. But that's a struggle for us.
We've done some workarounds because currently we have the same electronic health record, but we do our charting in a separate program called ASET. However, in the Allscripts Enterprise, the electronic health record that the physicians use, we've placed in some things like we have a banner alert that shows that any care management program that the patient is involved in is on a banner. And when that opens up, the physician has the ability to see who the care manager is and what their phone number is. Any communication that we have with the physician, direct communication, goes through an internal sort of an email system called a task system. And then we do have the ability to turn that task into a progress note. I'd like to add is that, and we've called that our secret sauce in the past, is that we hired a triage nurse for and the role, we weren't quite sure what the triage nurse was going to do when we hired. It happened to be a her at the time. And in the end, we find that that role is invaluable for all of our care management programs. So referrals flow through triage and are placed in the most appropriate program. And the triage nurse has full knowledge of all of the programs that are available and can synthesize from the patient information where this patient should go. We initially started out for our triage nurse using a high-risk list. We generated a high-risk list. It didn't take very long for us to no longer need a high-risk list to find patients because we were receiving more and more physician referrals. And so for us, it helps us track patients, and we know where they're going, and we know that if that patient needs to change a program or needs different service, that our triage nurse will be involved again. And so we feel like it helps us keep track of where our patients are going, where they have been, and how they're doing.
And she's a face for our programs. And so you have to get the right personality also for that.
Exactly.
It's one point of contact for everybody, for the physicians, for the hospital, for our care managers, for me. When I want to know something, we all go to her. And she knows everybody. And the doctors start to really like her.
And it was very scary at first because we put her email and her phone number on everything. And we said, oh, and it was like, oh. And it worked out really, really well because over time, the method and the pathway is well understood, and things are going to her in a very manageable way. Although she might argue about that from time to time.
And we're stealing that idea. Just
okay.
Yeah, actually, we because of the success that Sharp Re-Steely has had with that, we're moving in that direction as well. The other thing that I think is vitally important, this is brand new, it's ever changing, and it's so important to make sure that that staff is nurtured, that you're meeting them frequently, that you understand the struggles that they are encountering. And so we have set up, and I'd said earlier, we have a weekly huddle with our staff. And there have been a couple of times where I've said to them, well, you know what, I know you're busy, and do you still need this? And I get a resounding, oh my gosh, yes. So it's a great time for team building, it's a great time for education, but also just a time for the staff to come together and just say, hey, I'm struggling with this patient, or I'm struggling with this issue, and how do we streamline? So as we look at process improvement within our program, it's vitally important to get that frontline staff member's opinion or information, because they're the experts at what they're doing on a daily basis. So that has been pivotal for us to really refine and develop this program, but also to make sure that we're providing that opportunity where they feel like they are heard, where they're nurtured, because it can be pretty lonely sitting out there by yourself.
Could I just add to the triage nurse? One of the things I think really helps having that role is that she helps fill some of those gaps between transitions of care. So I might be working with the patient, but then the patient gets hospitalized. And we don't still have a great way of us being on the ground of knowing when are we getting, who is where, but triage gets notified of these things and knows where they're going, and so it helps us to, again, fill the gaps, know who's where, and then decide, is this still the best place for this patient, or should we put them in a different program, or just coordinate their care?
Well, thank you so much, panel. It's been a heartwarming stories.